I'm going to talk to you about a completely different approach to getting your PhD. So I'm Marie Bibby-Jones, and I'm going to not go too much into my career journey, because when I left university in 1999 with my mathematics Master of Philosophy, I wanted absolutely nothing more to do with academia, quite like my colleagues here. So I chose a series of organisations to work for that worked with data and let me use my statistical skills, and that's what I was really excited about. So there's a number of organisations there. But then I saw an advertisement in 2013 to work with both Sussex Partnership in the research department on mental health research studies, and also to be a research advisor with the Research Design Service. And I thought that sounded fantastic, but I still wasn't thinking about academia at this point. So in those two roles, I found myself working with clinicians, clinical academics, practitioners, helping them with their data, designing randomised controlled trials or clinical studies. And at the same time, I was embedded within the University of Brighton, and there's a School of Health Sciences team as well there. And they were doing these really big surveillance studies that were working across Europe, and that sounded pretty cool. So I got involved in that as well. And what was nice was that I was getting lots of exposure to these, clinical studies that were quite small, and then these surveillance studies that were, really big. So I became an academic by accident. I ended up with about 35 papers by 2021, but the problem for me was that they were in a whole range of different areas. I had mental health, I had sexual health, physical health, and I had one cancer paper from when I was at the Institute for Cancer Research. Nigel Sheriff, who was here earlier, Professor Nigel Sheriff, suggested that I take my 35 papers and I use a subset of them to submit for a PhD by publication, which was something I had not even considered before. So in 2021, I registered with the University of Brighton, and I was assigned what I call the dream team of professors, which was Kate Galvin, Greg Cooper, and also Nigel Sheriff. And their role was really to help me select a subsection of my 35 papers that would help represent why I should be given a PhD based on the work that I've done today. So it was a lot of critical appraisal, a lot of self-reflection, pulling apart my papers, thinking about the strengths and the weaknesses, thinking about, what's so special about me being a part of these different research teams and being embedded in these different clinical teams. And they kept talking to me about the golden thread. It took me ages to find the golden thread. I just didn't know where am I going with this golden thread. But by pulling apart my papers and thinking about, well, how are they different, but also how are they similar? The topic areas for a lot of the papers, the people that we were recruiting to the studies, they either had serious mental illness, so things like psychosis, voice hearing, or OCD. Other people were at higher risk of developing mental health difficulties. So these were people who use drugs, that's PWD, or men who have sex with men. So I felt like they were all linked by mental health risk, either having it or being at a high risk of mental health difficulties. Then I looked at how the data was being collected for these different groups of people. So I had electronic health records data, I had clinical trials, clinical service data, and also the surveillance data. And all of these different sets of data were collected through community services or projects that were delivered in the community. And this is how we engaged with these different groups of people. So that was basically what I hooked my golden thread on. Then I needed to think about the data. All the data sets are all completely different. They all bring different challenges, whether it's how you collect it or whether or not there's missing data. How do you minimise that missing data? how do you make sure that your data is of good enough quality that by the time it is analysed by myself, that you can come to conclusions that are robust, that you can have quite a lot of confidence in, that you can use for clinical insight, and that clinicians and practitioners could use that data and those findings to make really important decisions about whether or not to treat patients and service users with certain interventions, or whether or not there needed to be a screening process before an intervention was offered, instead of doing that automatically. So underlying all of that, I then had to do a critical appraisal of myself, which was fun. So I had to think about, what do I bring to these different clinical teams or these different research teams that I'm working with. I'm bringing a toolbox of statistics. So what are those statistics, and why can't those people in the clinical teams or in the research teams, why can't they do that themselves? So I really had to draw out this narrative that kind of wove in between, all of those things that I've just highlighted here. And the way that you write the thesis, or that I wrote my thesis, was all of that critical appraisal and narrative was the first part of it. And then the results were the themes. So these were the themes that I was saying, this is what I'm bringing to the table by being embedded within these clinical teams and the research teams. So I said that through my work, I'm able to improve treatment, engagement and outcomes, and I can make interventions and services more efficient. I'm also bringing my skills in translating findings from randomised controlled trials that are they're designed, they're really well resourced, they've got lots of people, lots of hands on deck to make these randomised controlled trials happen. But then what happens to the findings from those results when you deliver it in the real world? So you've got the busy clinician, you haven't got all the staff that you're supposed to have, etc. So what is the difference between those two, and what do I do to help maximise the efficiency of the data so that we can kind of represent that? And then the last theme was about using these particular skills that I use to design research clinical trials, and thinking about what I was calling meaningful difference. So when we design a randomised controlled trial, we want to detect a difference that is meaningful. What I was noticing in service evaluations and in the real world is that clinicians were really focused on what we call p-values, which tell you whether or not your finding is significant. It doesn't tell you whether it's clinically meaningful or not. So what I try to do with the teams that I was working with is to kind of use that concept more and make sure people talk about their findings in that way, and not just presenting these magical p-values. So that was the PhD. So with the themes as my results, I then had to do a discussion, have a set of recommendations, and then in the appendices I laid out all of my 9 selected papers. Then in the body of the thesis, every time I'm making a statement, I then reference one of my 9 papers, or a selection of them. But you can do it in such a way that actually I could tap into the other kind of 26 papers that I had as well, if it was relevant. I submitted that in February 2022, and I had a viva in April 2022, and I passed. So that is a kind of Thank you. So that is, that's a completely different approach to doing it. It took a year. I have to admit, it was really intense. It was weekends, missed, and evenings after work. I didn't quite cry, but I felt pushed to tears sometimes. But it is really worth it, in my opinion, because I knew at the end of a year I was going to have this PhD based on the work that I'd already done. I'd already done 50% of the work in that respect. There are 2 ways of doing it. So if you're someone like me who's worked with lots of teams and's got lots of papers, and you think you can weave that golden thread, then register, do it the same way that I've done it. But if you're thinking this is actually a helpful way and you're in clinical practice and you are going to have a whole series of outputs anyway, then why not work with a supervisor or with a team to kind of navigate strategically how these could all add up to a PhD in the future. So that's it. That's all I wanted to say.